Welcome back to the Deep Dive.
Good to be back.
Today we're diving into something, well, it's right at that intersection of immediate danger and really crucial long-term care. We're talking about managing blood clots, thromboembolic disorders.
Yeah, it's definitely one of the most high-stakes areas in medicine, I'd say. Arterial clots causing heart attacks, venous ones leading to PE.
Life and death, absolutely.
And we're looking at these three major drug classes today: anticoagulants, antiplatelets, and thrombolytics.
Right.
All designed to step in when the body's own clotting system, which is usually miraculous, right, when it goes wrong.
When it misfires. And our sources today, they look pretty comprehensive. Lots on mechanisms, uses, safety.
Absolutely. We've got a solid base to work from, detailing exactly how these drugs work, when to use them, and crucially, what to watch out for.
So our mission today is really to get under the hood, understand how they mess with the clotting system. But first, we absolutely have to, nail the foundation, hemostasis, clotting itself.
Yeah, you can't understand the drugs without understanding the process they're targeting. So clotting, when it works right, it's basically two stages.
Okay.
Stage one is the immediate fix, formation of the platelet plug. Vessel breaks, platelets rush in, stick together, aggregate, boom, initial blockage.
That's the quick seal, like if you cut your finger.
Yeah.
Stops the immediate gush.
Exactly. But that plug, it's not super strong on its own. It needs reinforcement.
And that's stage two.
That's stage two. Coagulation. This is the complex cascade, intrinsic, extrinsic pathways, all these factors activating each other in a chain reaction.
A chain reaction leading to?
Leading to fibrin. That's the goal. Fibrin is this fibrous protein.
The meshwork, the scaffolding that makes the clot strong.
Precisely. It stabilizes that platelet plug, makes it durable while the vessel heals.
Okay, so if you get those two stages, platelet plug first, then fibrin mesh, the drug groups make sense.
Immediately. You can see where each one fits.
Let's define them then, based on what they target.
Okay. First up, anticoagulants. They mostly work on stage two. They disrupt that coagulation cascade, suppress the fibrin production, stop the scaffolding from being built properly.
Got it. No scaffolding. What about the second group?
Antiplatelets. They go after stage one. Inhibit platelet aggregation. Stop those initial bricks, the platelets, from sticking together in the first place.
Okay, stop the bricks. And the third? The big guns.
Yeah, the thrombolytics, they're different. They don't prevent. They attack an existing clot. They promote lysis, the breakdown of the fibrin that's already there. They dissolve the thrombus.
Dissolve it. Okay, that distinction is really key. Preventing versus dissolving.
Well,
Let's start our deep dive with the anticoagulants then, the ones messing with the fibrin chain. All right, anticoagulants. Looking at our sources, there seems to be sort of a fork in the road in terms of how they actually reduce fibrin. Two main methods.
yeah, it's a pretty clear split, actually. Method one is stopping the body from making the clotting factors in the first place, inhibiting synthesis.
Like cutting off the supply chain.
Exactly. And the classic drug that does this is warfarin. We'll definitely get into that one.
Okay, inhibiting synthesis. And the other method. That covers pretty much everything else.
Pretty much. Method two is inhibiting the activity of the clotting factors that are already there floating around.
So the factors are made, but they can't do their job.
Right. These drugs target key players like factor SAA or thrombin, sometimes both, and just stop them from working in the cascade. Hashtag 1.1 heparin, unfractionated, and its rapid action.
Let's kick off with a classic. Heparin. Unfractionated heparin, rapid acting. But the mechanism is interesting.
Yeah.
It's not quite direct, is it?
No, it's fascinating. Heparin works by amplifying something the body already has, antithrombin.
Antithrombin.
Antithrombin is like the body's natural brake on clotting. It inactivates key factors, especially thrombin and factor SAA. Heparin grabs onto antithrombin, changes its shape, and makes it maybe 1,000 times more effective at neutralizing those clotting factors.
Wow, so it supercharges the body's own control mechanism.
Exactly. It's an indirect boost, but a really powerful one.
And quick aside, for the trivia lovers, the source,
Okay.
still pretty old school, right?
Oh, yeah. Our sources confirm, commercially, it's still derived from lungs of cattle and intestines of pigs.
Amazing. A life-saving modern drug from animal organs.
It's a good reminder of where some of our medicines come from. But clinically, the key thing about heparin is its size and how it's given. It's a big molecule.
So injection only?
Injection only. 5E, often a continuous drip, sometimes intermittent or a deep subcutaneous injection. And the absolute reason you reach for heparin is when you need anticoagulation fast.
Right. Speed is the key.
Yeah.
So what situations demand that kind of immediate action?
Acute danger, basically. treating a massive DVT or a big pulmonary embolism right now.
Okay.
During procedures like open heart surgery or renal dialysis where blood hits foreign surfaces and you have to prevent clots instantly.
Makes sense.
Also for strokes that are actively getting worse or in DIC, disseminated intravascular coagulation. And importantly, it's often the go-to anticoagulant during pregnancy.
Why pregnancy specifically?
Because unlike warfarin, heparin doesn't cross the placenta, so it's safer for the fetus.
Got it. Now, with that kind of power and speed, the risks must be significant. Bleeding is the obvious one, but there's this weird paradoxical thing, HIT.
Ah, yes. Heparin-induced thrombocytopenia, HIT. It's an immune reaction. The body basically makes antibodies against a complex of heparin and a platelet factor.
Okay, immune reaction. Low platelets thrombocytopenia. But you said paradoxical.
Right, because even though the platelet count drops, the risk of clotting thrombosis goes up dramatically.
Wait, what? How does thinning the blood and losing platelets lead to more clots? That sounds backwards.
It does, but the immune complexes formed aren't just destroying platelets, they're activating the remaining ones. And they activate the lining of the blood vessels, too. So these activated complexes are super thrombogenic. They trigger widespread runaway clotting. It's dangerous. Our sources say it happens in maybe 0.2 up to 5% of patients on heparin for more than 4 days. So not super common, but definitely a real threat.
Yikes. Okay, so if things go wrong the other way, too much heparin, major bleeding, is there an antidote?
Yes, there is. Protamine sulfate. It's given as a slow IV injection.
Slow 4.
And the effect is immediate, lasts about 2 hours. It works by chemically binding to heparin. There's a precise calculation, too. 1 milligram of protamine neutralizes about 100 units of heparin.
Precision is key there. Which brings us to monitoring. Unfractionated heparin sounds like it needs constant watching, high alert medication, right?
Absolutely. One of the highest. The patient response varies so much, you need really tight lab surveillance to get the dose right.
So what are we measuring?
The main test is the APTT-activated partial thromboplastin time. It measures how quickly the blood clots via specific pathways, the intrinsic and common ones.
And how often are you checking that APTT?
Frequently. Every 4 to 6 hours when you're starting or adjusting the dose until it's stable in the target range.
Which is?
Usually aiming for an APTT of about 60 to 80 seconds. Too low, risk of clotting. Too high, risk of bleeding.
Is there an alternative test?
Yes, you can measure the anti-factor I level. It's a more direct measure of heparin's activity. Same monitoring frequency every 4-6 hours, looking for a range of maybe 0.3 to 0.7 IU/mL.
So why isn't anti-ESA used all the time if it's more direct?
Cost, mostly. The APTT test is just significantly cheaper.
Got it. And administering this, continuous IV drip, weight-based initial dose. But the thing that really jumps out is the 2RN check.
That tells you everything, doesn't it? The risk level. 2 registered nurses have to independently verify the drug, the dose calculation, the pump settings, everything before starting. And with any dose change, it's a critical safety net for a drug where errors can be catastrophic.
Intense.
Yeah.
Unless it's just for prevention.
Exactly. If you're using low-dose therapy purely for prophylaxis, preventing clots, not treating existing ones, then it's different.
How so?
A typical dose might be 5,000 units subcutaneously every 8 or 12 hours, and in that specific low-dose scenario, you generally don't need APTT monitoring.
Oh, okay. So the monitoring intensity really depends on why you're using it.
Precisely. Therapeutic dose needs constant checks. Prophylactic low dose usually doesn't. Hashtag tag 1.2 low molecular weight LMW heparins.
Okay, that's unfractionated heparin.
Yeah.
Now let's talk about the LMW's low molecular weight heparins, like enoxaparin, which people might know as Lovenox, or dalteparin. What's the difference? Are they just smaller heparin?
Essentially, yes. They're made by breaking down the long chains of unfractionated heparin into shorter pieces.
And does that change how they work?
It does. Remember how unfractionated heparin inhibits both factors ISA and thrombin pretty equally?
Yeah.
LMW heparins, because they're shorter, preferentially inhibit factors A. They have less effect on thrombin. And this makes their action much more predictable from person to person.
More predictable. And that's the key advantage, right? The big takeaway for people learning this.
Absolutely. That predictability is the game changer. Because the response is so much more consistent, LMW heparins do not require that intensive lab monitoring, no routine APTTs or anti-AXA levels needed.
Wow. So no constant blood draws? That's huge.
It's massive. It means patients can often be taught to give themselves injections at home. They get sent home with pre-filled syringes. Huge convenience factor.
Where do we see these used most often then?
They're really common for preventing DVTs after major surgeries, big abdominal operations, hip replacements, knee replacements. Standard practice.
Okay.
And they're also used to treat Established DVTs and PEs, often bridging to an oral anticoagulant, or sometimes for the whole treatment course, especially if someone can manage injections at home.
So effective anticoagulation without being tied to a hospital bed or clinic. What about the risks? Is bleeding still a concern?
Oh yes, bleeding is still the main adverse effect. You're still thinning the blood, but
Yeah.
the data suggests the risk is generally less than with unfractionated heparin.
Less risk, no monitoring? Sounds pretty good. Any specific catches?
There is one major caution, a boxed warning actually. There's a risk of serious neurologic injury, spinal or epidural hematomas, if a patient getting LMW heparin undergoes a spinal tap or gets epidural anesthesia.
A bleed near the spinal cord? That sounds bad.
It can be devastating, causes paralysis. So timing around those procedures is absolutely critical if someone's on an LMW heparin. Hashtag tag 1.3 warfarin. Coumadin, Jontovin, the vitamin K antagonist.
All right, we've covered the injectables, the fast-acting heparins. Let's switch gears completely to the old standby, the long-term oral anticoagulant, warfarin, also known as Coumadin or Jontovin.
Ah, warfarin, such a history.
Right. We mentioned the background discovered when cattle ate spoiled sweet clover silage, then used as rat poison.
Warfarin from the Wisconsin Alumni Research Foundation, which patented it initially as a rodenticide.
And then it comes back into medicine after a failed suicide attempt showed it could actually be managed in humans. Just wild.
It's an incredible story. But the key thing to grasp is its mechanism. Unlike heparin, warfarin works by being a vitamin K antagonist.
Okay, vitamin K, the clotting vitamin. So warfarin blocks it.
Exactly. Your liver needs vitamin K to produce several key clotting factors, specifically factors 7, IXX, and prothrombin. Warfarin gets in the way, blocking the action of vitamin K.
So the liver just can't make functional versions of those factors anymore.
Correct. It inhibits the synthesis of new active clotting factors.
And that's why it has a delayed onset, right? It doesn't do anything to the factors already circulating in the blood.
Precisely. The factors already there have to degrade naturally over several days before you see the full anticoagulant effect of warfarin, which means
It's no good in an emergency.
absolutely useless for acute situations. Warfarin is all about long-term prevention, prophylaxis.
So where is it the standard of care for that long-term prevention?
It's been the mainstay for decades for preventing venous thrombosis and PE recurrence, managing clot risk in patients with mechanical prosthetic heart valves, that's a big one,
Okay.
and very commonly used to prevent strokes in patients with atrial fibrillation, or AFib.
It's been around forever. It's cheap.
Super cheap. And there's just tons of clinical experience with it, but the monitoring, that's the other side of the warfarin coin.
Yeah, let's talk about that. It's legendary for being complicated, requiring serious patient commitment.
It really is. You monitor warfarin using the PT, prothrombin time, and more importantly, the INR, International Normalized Ratio.
INR. Why the INR, not just the PT?
The INR standardizes the PT result. Different labs might use slightly different regions for the PT test, which can give different results. The INR calculation corrects for that, so an INR of, say, 2.5 means the same thing regardless of where the test was done.
Makes sense. And what's the target INR range?
It depends on why the patient is on warfarin, but for many common indications like AFib or DVT-PE treatment, the target range is usually 2.0 to 3.0. For mechanical heart valves, it might be higher, like 2.5 to 3.5.
And getting into that range and staying there,
Yeah.
that's the challenge, right? The monitoring schedule sounds intense.
It is. You might check the INR daily for the first 5 days of therapy, then maybe twice a week for a couple of weeks, then weekly. Then, if someone is incredibly stable, maybe you can stretch it out to every 2 to 4 weeks.
Wow.
But any change in medication, diet, or health status can throw the INR off, and you might need more frequent checks again. It requires huge patient education and compliance.
And they need a medical alert bracelet.
Absolutely essential. So healthcare providers know immediately they're on warfarin in an emergency.
Okay, practical question. We're about to talk about newer drugs, the DOACs that don't need all this monitoring.
Yeah.
Why is warfarin still so widely used then?
Great question. 3 main reasons, really. 1, cost. Warfarin is incredibly inexpensive.
Very cheap.
2, familiarity. Decades of experience mean clinicians are very comfortable managing it despite the complexity. And 3, and this is crucial, specific indications. For patients with mechanical heart valves, current evidence still strongly supports warfarin over the DOACs.
Ah, okay, so it still has its place, especially there. Now, interactions.
Yeah.
This seems like a minefield with warfarin.
It's a huge challenge. Our sources group them into 3 big categories. First, drugs that increase warfarin's effects make the INR go up, increase bleeding risk.
Examples.
Things like aspirin, many antibiotics like sulfonamides, even high doses of acetaminophen can do it.
Okay. Second category.
Drugs that just generally promote bleeding, even if they don't change the INR much. Think other anticoagulants or antiplatelets like clopidogrel or dabigatran. Taking them with warfarin is double trouble.
Makes sense. And the third.
Drugs that decrease warfarin's effects make the INR go down, increasing clot risk. This includes certain seizure meds like carbamazepine, some antibiotics like rifampin, even oral contraceptives.
So basically, any new medication, even over-the-counter stuff or supplements, needs careful consideration and probably an INR check.
Absolutely. It's essential. And it's not just drugs.
The diet connection, vitamin K.
Exactly. Since warfarin works by blocking vitamin K, changes in dietary vitamin K intake can mess with the INR.
What foods are high in vitamin K?
Green leafy vegetables are the big ones. Spinach, kale, broccoli, Brussels sprouts. Also things like mayonnaise, canola oil, soybean oil.
So do patients have to avoid these foods?
No, that's a common misconception. Vitamin K is important for health. The key is consistency. Patients need to keep their intake of vitamin K-rich foods relatively stable from week to week.
So don't suddenly start eating massive salads every day, if you weren't before, or suddenly stop.
Exactly. Sudden big changes will affect the INR. Consistency is the goal.
And the risk in pregnancy. We touch on this with heparin.
Warfarin is a definite no in pregnancy. Category X. It crosses the placenta and can cause fetal hemorrhage and significant birth defects, teratogenesis. Big contrast with heparin there.
Okay, and if you do need to reverse warfarin quickly, too high in INR or bleeding?
You give back what warfarin is blocking. Vitamin K.
Makes sense. How is it given?
It can be given orally, PO, or intravenously, IV, depending on how quickly you need the reversal. 4 is faster, obviously. It allows the liver to start making functional clotting factors again.
That detailed look at warfarin, especially the complexity, perfectly sets up the next stage.
Yeah.
The modern alternatives, the direct oral anticoagulants or DOACs.
Yeah, this really represents a major shift. We're moving away from indirect methods like boosting antithrombin with heparin or blocking vitamin K synthesis with warfarin.
Some more targeted approaches.
Exactly. DOACs directly target specific clotting factors, usually either thrombin or factors A. And that precision has huge implications for ease of use.
Let's start with the ones that target thrombin directly.
Yeah.
The main example here is dabigatran, brand name Pradaxa. How does its action differ from heparin, which also affects thrombin?
Key difference. Heparin needs antithrombin as a middleman, right? It boosts antithrombin.
All right, indirect.
Dabigatran binds directly to thrombin itself, the active site, and inhibits it. No middleman needed. It just shuts down that final enzyme in the cascade that generates fibrin.
Okay, direct inhibition of thrombin. And the big advantages compared to warfarin. This is what everyone wants to know.
There are several huge ones. First, and probably biggest, no routine monitoring needed, no INRs.
Wow. Just take the pill?
Pretty much. Second, far fewer significant drug interactions and virtually no food interactions to worry about.
That simplifies things massively for patients.
Hugely. And third, often a fixed dose can be used for most patients, regardless of age or weight, although dose adjustments are needed for kidney impairment.
That combination, fixed dose, no monitoring, fewer interactions, that's the warfarin escape route everyone was hoping for. So where is dabigatran primarily used?
Its biggest use is preventing stroke and systemic embolism in patients with non-valvular AFib. That's a major indication.
Non-valvular AFib.
Okay. It's also approved for treating DVT and PE, usually after an initial period of injectable anticoagulation, and for preventing DVT-PE after hip or knee replacement surgery.
And a typical dose for AFib?
The standard dose is 150 milligrams twice a day.
Got it. Now, being newer, does it have a specific reversal agent if serious bleeding occurs? Warfarin has vitamin K, heparin has protamine.
Yes, it does. The antidote for dabigatran is idarucizumab, brand name Praxbind.
Idarucizumab. How does that work?
It's a monoclonal antibody fragment that specifically binds to dabigatran molecules and neutralizes them very quickly.
Clever.
Yeah.
Any other key points about dabigatran? How is it cleared from the body?
Good point. It's primarily eliminated by the kidneys. That's really important. Meaning you have to be cautious and often adjust the dose in patients with kidney problems. You need to monitor their renal function. And it also means you need to stop the drug well before elective surgery, usually 1 to 5 days before, depending on kidney function to make sure it's cleared out.
Okay, so dabigatran hits thrombin directly. The other major class of DOACs targets factors A instead. This includes drugs like rivaroxaban, Xarelto, apixaban, Eliquis, edoxaban, Savisa.
Right. Factors A is a great target because it sits at the convergence point of the intrinsic and extrinsic pathways. It's the step right before prothrombin gets converted to thrombin.
The final common pathway, essentially.
Exactly. So these drugs provide selective, direct inhibition of factors A. Rivaroxaban, for example, binds right to factors A and stops it from doing its job.
And do these factors A inhibitors share those same core advantages we saw with Dabigatran? Predictability, convenience?
Yes, absolutely. That's the hallmark of the DOAC class generally. Rapid onset compared to warfarin, fixed dosing for specific indications, no routine monitoring required, and generally fewer drug interactions than warfarin.
Can you give us an example of that fixed dosing, say for rivaroxaban?
Sure. For non-valvular AFib, in someone with normal kidney function, the dose is typically 20 milligrams once daily, taken with the evening meal.
Once a day. Easier than twice a day for Dabigatran.
Can be, yeah. And if the patient has moderate kidney impairment, you just reduce the dose, usually to 15 milligrams once daily.
Okay. What about treating a DVT or PE?
For treatment, there's usually an initial higher dose phase for rivaroxaban. It's 15 milligrams twice daily for the first 21 days, followed by a maintenance dose of 20 milligrams once daily thereafter.
So, very prescribed regimens, simple instructions, take it at the same time each day.
Exactly. Much simpler for patients than managing INR levels.
What about safety for the factors A inhibitors? Similar concerns.
Bleeding is still the main risk, of course, and that warning about spinal epidural hematomas applies to them too.
Right.
You also need to use them cautiously or adjust doses in patients with significant renal or hepatic impairment, as that affects how the drugs are cleared. And, like warfarin and unlike heparin, they are generally considered unsafe in pregnancy.
Got it. And antidotes for this group. If someone is bleeding significantly on rivaroxaban or apixaban.
For an acute overdose, like if someone takes too many pills, activated charcoal can help if given soon after ingestion. The specific reversal agent developed for factors as inhibitors is andexanet alpha.
Andexanet alpha, how does that one work? Is it like Idaru's Sizumab?
Sort of similar concept, but different target. Andexanet alpha is basically a decoy factor ZA molecule. It's modified, so it's inactive in clotting, but it still binds avidly to the factor ZA inhibitor drugs.
So it soaks them up.
Exactly. It acts like a sponge, binding the drug so the real factor ZA can get back to work if needed for hemostasis.
Okay, we spent a good chunk of time on anticoagulants, the drugs that interfere with the fibrin mesh, stage 2 of clotting.
Yeah.
Now we need to shift focus back to stage 1.
Back to the beginning of the process.
Right. Platelet aggregation. And the drugs that target this are the antiplatelets, crucial for arterial clots, right?
Very much so. While anticoagulants are maybe more dominant for venous clots like DVTs, antiplatelets are really the cornerstone for preventing arterial thrombosis heart attacks, strokes caused by clots in arteries. Hashtag tags 3.1 aspirin, ASA.
And when you think antiplatelet, the first one that comes to mind has to be aspirin. Acetylsalicylic acid, ASA.
Yeah.
Been around forever.
The absolute king in antiplatelets. Simple, cheap, effective. Its mechanism is inhibiting an enzyme called cyclooxygenase, or COX, specifically FeOX1 in platelets.
And what does COX do normally?
COX is needed to make thromboxane A2. Thromboxane A2 is a chemical messenger that strongly promotes platelet aggregation, makes platelets stick together, and also causes vasoconstriction.
So aspirin blocks the production of this stickiness signal.
Exactly. And importantly, aspirin's effect on COX in platelets is irreversible. It permanently knocks out the enzyme for the entire lifespan of that platelet, which is about 7 to 10 days.
Wow. Irreversible. That's potent. No wonder its uses are so widespread in heart disease and stroke prevention.
The list is huge. Preventing ischemic stroke and TIAs. Reducing risk in chronic stable angina, unstable angina, absolutely critical after coronary stenting to prevent the stent from clotting off.
Yeah.
Reducing mortality after a heart attack and preventing future heart attacks. It's just a fundamental drug in cardiovascular medicine.
What about primary prevention? Preventing a first heart attack or stroke in people who haven't had one yet.
That's more nuanced. The guidelines have evolved. Our sources mention specific age ranges where the benefit was thought to outweigh the risk, like men 45-79, women 55-79. But recommendations for primary prevention are more individualized now, considering overall cardiovascular risk versus bleeding risk.
Because bleeding is the main downside.
It is.
Yeah.
And the dosage for long-term prevention is usually quite low, isn't it?
Often just 81 milligrams a day, the baby aspirin dose.
Yeah.
That's usually enough to get the needed antiplatelet effect systemically. Higher doses, like 325 milligrams, might be used initially in acute situations, like during a heart attack.
Okay, let's talk about that bleeding risk. Where does it usually manifest? The big concerns are GI bleeding, gastrointestinal bleeding, and hemorrhagic stroke bleeding in the brain.
And there's a common belief about enteric-coated aspirin
Yeah.
that it protects the stomach.
Right, people think the coating prevents bleeding, but our sources are clear. Enteric coating might reduce stomach upset or local irritation,
What?
but it does not reduce the risk of major GI bleeding or hemorrhagic stroke. That risk comes from aspirin's systemic effect on platelet function throughout the body, not just its local effect in the stomach. That's a really important point for people to understand.
Good clarification. Systemic effect, systemic risk. Hashtag tag 3.2 clopidogrel. Plavix. Okay, beyond aspirin, another major antiplatelet drug is clopidogrel, brand name Plavix. Works differently than aspirin, right?
Completely different pathway. Aspirin hits COX and thromboxane. Clopidogrel is an ADP receptor antagonist.
ADP, adenosine diphosphate.
Exactly. When platelets get activated, they release ADP, which then binds to receptors on other platelets, telling them to aggregate too. It's like a recruitment signal. Clopidogrel specifically blocks one type of these receptors, the P2Y12 ADP receptor, on the platelet surface. So ADP gets released, but it can't deliver its come join the clot message effectively.
Stops the recruitment signal. Clever. Where is clopidogrel mainly used?
Big use is in patients with acute coronary syndromes, ACS, that includes unstable angina and certain types of heart attacks and CMI. It's also vital for preventing clots forming inside coronary stents after they've been placed, and for secondary prevention after a heart attack or stroke, sometimes as an alternative if someone can't take aspirin.
Now, there's something really important about how clopidogrel is activated in the body, isn't there? A genetic factor.
Yes, this is critical. Clopidogrel is a prodrug. It's inactive when you swallow it. It needs to be converted into its active form by an enzyme in the liver, specifically CYP2C19.
Okay, CYP2C19, why is that important?
Because there's significant genetic variation in how well this enzyme works. Some people are poor metabolizers. Their CYP2C19 enzyme is underactive.
So they can't activate clopidogrel properly.
Exactly. They take the drug, but they don't get the full antiplatelet effect, leaving them at higher risk of clotting, like stent thrombosis. Genetic testing for CYP2C19 variants is sometimes done now, especially in high-risk situations.
Good to know. Any other major risks with clopidogrel besides bleeding?
There's a rare but very serious condition called thrombocytopenic purpura, TTP, that's been associated with it.
TTP, what is that?
It involves widespread small clot formation throughout the body's small blood vessels, consuming platelets, so you get thrombocytopenia, and causing organ damage. It's a medical emergency. Rare, but need to be aware of it.
Okay. And in those key situations like ACS or after stenting, how is clopidogrel usually given? Alone?
No, in ACS and for stent protection, clopidogrel is almost always given together with aspirin. It's called dual antiplatelet therapy, or DAPT.
Dual therapy. Hit platelet activation from two different angles.
Precisely. Maximizes the antiplatelet effect during that high-risk period. The typical maintenance dose of clopidogrel is 75 milligrams once daily, orally. Hashtag 3.3 glycoprotein, GP-ibadiol receptor antagonists, the super aspirins.
Aspirin, clopidogrel.
Okay.
Now, our sources mention another class, sometimes called the super aspirins, the glycoprotein receptor antagonists.
Yeah.
Drugs like eptifibatide, tirofiban, are they really that much more potent?
They are considered the most effective antiplatelet drugs available. They hit the final ultimate step in platelet aggregation.
The final common pathway for platelets sticking together.
Exactly. Think about it. Aspirin blocks thromboxane, clopidogrel blocks ADP signaling, but there are other things that can activate platelets too. All those activation pathways ultimately lead to one final action, changing the shape of the GP-ibadiol receptor on the platelet surface.
Okay, what does that receptor do?
The activated GP-ibadiol receptor is what allows platelets to link together using fibrinogen as a bridge. Fibrinogen floating in the blood basically acts like glue, connecting the GP-ibadiol receptors on adjacent platelets.
Ah, so it's the actual linking point.
So it's the handshake between platelets. These drugs, the GP-ibadiol antagonists, block that receptor. They prevent fibrinogen from binding.
So it doesn't matter how the platelet got activated upstream.
Doesn't matter. If the GP-ibadiol attacker is blocked, the platelets simply cannot form a stable aggregate. It shuts down the final step completely.
Wow. Okay, that is powerful. So where are these super aspirins used? Must be high-risk scenarios.
Absolutely. Primarily used short-term during high-risk percutaneous coronary intervention, PCI, angioplasty and stenting, especially if there's a large clot burden or complex procedure to prevent acute vessel closure.
In the cath lab, basically.
Yes. And also sometimes used in managing high-risk acute coronary syndromes, unstable angina or NSTEMA, before or during intervention.
And how are they given? Oral pills.
No, these are only given intravenously. Continuous infusion, typically in a critical care or cath lab setting.
40 only.
Yeah.
Makes sense for that level of potency and acute use. What about duration? Is the effect permanent like aspirin?
No, thankfully. Their blockade of the receptor is reversible. Platelet function starts to recover within about 4 hours after stopping the infusion.
That's a key safety feature, right? If bleeding happens, you can stop the drug and the effect wears off relatively quickly.
Exactly. It gives you an off switch that you don't really have with aspirin or clopidogrel once the dose is taken.
Okay, we've covered preventing clots with anticoagulants and antiplatelets. Now, for the final section, we tackle a situation where the clot has already formed and is causing a major problem. We need to get rid of it.
Time for the heavy artillery. Thrombolytics, or clot busters.
And the main one used today is alteplase, which is recombinant tissue plasminogen activator, or TPA.
That's right. Here, the goal isn't prevention anymore. It's active lysis breaking down the fibrin that's holding the clot together.
So how does TPA actually chew through that fibrin mesh?
Well, TPA itself doesn't do the chewing. It's more like a catalyst or an activator. The body has an inactive enzyme precursor called plasminogen circulating in the blood and trapped within clots.
Okay, plasminogen. Inactive.
TPA binds to plasminogen, specifically on the surface of the fibrin clot. This binding forms an active complex.
And that complex does what?
That complex then converts other nearby plasminogen molecules into their active form, which is plasmin.
Ah, plasmin. That's the enzyme that does the work.
That's the enzyme. Plasmin is what actually digests the fibrin strands, breaking down the clot structure from the inside out. Think of it like molecular scissors cutting up the fibrin net.
Very cool. So TPA just kickstarts the body's own clot-dissolving machinery, but ramps it way up.
Exactly. It promotes the conversion of plasminogen to plasmin much more rapidly than would happen naturally.
Given this power-dissolving established clots, these drugs must be reserved for true emergencies where time is critical.
Absolutely. Time is brain, time is heart muscle, time is lung tissue. The main uses are acute myocardial infarction, heart attack, acute ischemic stroke, clot blocking blood flow in the brain, and massive pulmonary embolism.
And for stroke especially, there's a really tight time window, right?
Critically tight. For ischemic stroke, TPA generally needs to be given within 3 to 4.5 hours of symptom onset for the potential benefits to outweigh the risks. That's why public education on stroke symptoms, fast face, arms, speech, time, is so important. Getting treatment quickly is paramount.
Okay, let's talk risks. If you're dissolving clots systemically, the biggest fear has got to be
Bleeding, uncontrolled bleeding, and the most devastating form is intracranial hemorrhage, bleeding inside the skull.
Why is that the biggest fear?
Because TPA doesn't just dissolve the bad clot causing the stroke or heart attack, it can also dissolve good clots that might be plugging tiny, fragile blood vessels elsewhere, especially in the brain. Turning an ischemic stroke into a hemorrhagic one is the nightmare scenario.
A catastrophic risk. How is severe bleeding managed if it happens while someone's on TPA?
Well, if it's external bleeding, direct pressure is the first step.
Yeah.
For internal bleeding, especially intracranial, you stop the TPA immediately. You give supportive care blood transfusions, maybe packed red blood cells, fresh frozen plasma to provide clotting factors.
Is there a specific reversal agent?
Yes, there are antifibrinolytic drugs like aminocaproic acid, Omicron, or tranexamic acid. They work by inhibiting the conversion of plasminogen to plasmin, essentially shutting down the clot-dissolving process that TPA initiated.
Okay. Now, alteplase, TPA, is the standard now. Are there advantages over older thrombolytics?
Yes, a couple of key ones. Alteplase is a recombinant form of human TPA, so it's less likely to cause allergic reactions compared to older agents derived from bacteria, like streptokinase.
Less allergy risk. Good.
And it also doesn't tend to cause hypotension, low blood pressure, to the same extent as some older agents, which is important when you're treating someone who might already be unstable from their clot.
Makes sense. Finally, safety logistics. Giving TPA sounds like it requires extreme caution from the whole team.
Extreme vigilance is the word. Because the bleeding risk is so high, you have to minimize any potential trauma.
Like what?
Minimize invasive procedures. Avoid sticking needles into the patient unless absolutely necessary. That means no subcutaneous or intramuscular injections if possible.
Right. Easy bleed sites.
Exactly. Careful handling of the patient. And critically, you need to stop or avoid using any other drugs that affect clotting concurrently.
So, no heparin, No warfarin, no TOACs, no aspirin, no clopidogrel while the TPA is being given.
Generally, no. Combining them drastically increases the hemorrhage risk. Managing a patient on TPA requires intense coordination and meticulous attention to detail from everyone involved: nurses, doctors, pharmacists. It's arguably one of highest intensity situations in acute care. Hashtag tag tag outro, synthesis, and final thought.
Wow, that was an incredibly detailed tour through the world of anticoagulants, antiplatelets, and thrombolytics. A huge amount of information.
It really covers a wide spectrum of interventions, doesn't it?
It does. So just to quickly recap the big picture,
Yeah.
we talked about anticoagulants like heparin and warfarin and the DOACs, which mainly work by blocking the synthesis or the activity of clotting factors, ultimately preventing fibrin formation.
Right, stage 2 inhibitors, mostly.
Then antiplatelets, like aspirin and clopidogrel, which stop the initial platelet plug from forming stage 1 inhibitors.
Preventing the bricks from sticking.
Mm-hmm.
And finally, thrombolytics, like TPA, which don't prevent anything, but actively dissolve the fibrin in clots that have already formed, the clot busters.
The wrecking crew, yeah.
And I think the key takeaway listening to all this is really understanding the mechanism, right? Knowing if a drug stops synthesis, blocks activity, prevents aggregation, or dissolves fibrin, that tells you almost everything about why it's used, how fast it works, and what you need to monitor for.
Absolutely. The mechanism dictates the clinical application and the risks. You connect those dots, and it all starts to make sense.
We've seen the whole range today, from something like warfarin, which requires this slow, complex, long-term management with constant checks and balances,
Decades of careful dose adjustment and monitoring.
all the way to TPA, this incredibly powerful immediate intervention, but one that carries this massive immediate risk, especially of brain bleeding.
Two completely different philosophies, really. Calculated long-term prevention versus high-stakes immediate destruction. So here's something to think about. Considering that immense risk of intracranial hemorrhage with TPA, the most potent clot buster versus the intricate long-haul management needed for warfarin, how different, fundamentally, is the risk-reward calculation when a clinician has to decide between preventing a potential future clot versus dissolving an existing, possibly fatal one right now?
That's a deep question.
That choice, weighing those vastly different timelines and risk profiles, that feels like the core drama playing out every day in managing these conditions, something for all of us to really chew on.